So this chapter is crime and mental disorders. Don't worry, this will be a short screencast. And it's a pretty short chapter in the book. You have a lot of other information, a lot of videos that I have assigned for this week. Make sure you focus on those. This is a really fascinating area, and it's really an area that I have a pretty decent amount of clinical experience in, but in a little different way. So this is South Florida State Hospital. This is the last place that I did I actually have a postdoc degree in psychopharmacology, and I did 2 internships here, but not as a psychologist, as a psychopharmacologist, which was kind of interesting. So I would go into team treatment meetings and assess the people that were hospitalized there, as far as their medication management, therapy, stuff like that. So there would be a psychiatrist that would lead the group, nurses, social workers, hopefully a psychologist was there. Honestly, they never were. Pharmacists, and then me. And once in a while there'd be some med students in there, or pharmacy students, and it was really interesting. So this is not a straight forensic hospital, but it's about 50-50. So about half the guys are there for forensic reasons. It's mostly males. They do have some females there. It is a beautiful building, and the campus is super nice. You might be used to state psychiatric hospitals that look something like this. This is Florida State Hospital. So, I'm not really sure in Wyoming, but they used to have huge hospital complexes like this, and they were almost like cities. Each state would typically have one. Larger states would have, more than one state hospital. That's where people went that had chronic mental illness. Then in the 1950s, there was a process that was called deinstitutionalization. Hopefully you've heard of that before. That corresponded right with the development of drugs that are used to treat psychosis, the antipsychotic drugs. So, through Nixon and Kennedy, the idea was to shut down these huge state mental hospitals and create smaller, localized community mental health centers. Well, unfortunately, they followed through on the first part of the plan, but they didn't follow through on the second part of the plan. Since that time, you also see a change in national drug laws. So our drug laws get quite a bit more severe. You see a huge increase in the homeless population and a gigantic increase in the population within the criminal justice system. I think that's directly related to the process of deinstitutionalization, because now we have a huge number of people in our criminal justice system that are receiving psychiatric care. Like in Wyoming, it's like a third of the inmates that are incarcerated receive psychiatric care. So Wyoming State Hospital is down in the southwest corner of the state in Evanston. I've never been there. I have no clue what it's like. Hopefully someday. Maybe some of you have been there, but I'm sure it's very similar. Now, when we talk about mentally disordered individuals in crime, there's this huge stigma against the mentally ill that they're dangerous. Dangerous, mentally ill, oh my God. And you hear of a lot of heinous crimes, like really bad things that happen, and the best explanation is, oh, that person must be crazy. Oh, well, I wish that was as easy as reality. And the reality is that mentally ill people are no more dangerous than regular old folks. There's one caveat there, in that they're probably more dangerous to themselves. So what you really have to worry about is suicide rates. I know the book doesn't really address that. In our country, suicide is a huge problem that's not discussed. So for every 2 murders in the United States, there's 3 suicides. So the suicide risk in mental illness goes way off the chart. The risk for violence, not so much. However, there are a couple disorders that are of note that I'd like to talk about. The book talks about depression. Depression Typically, I'm more worried about suicide. Then bipolar disorder. Bipolar disorder is often confused. So if you don't know what bipolar disorder is specifically, look up the DSM criteria for bipolar disorder. But when people are in a manic episode, sometimes they can be really self-destructive. But typically they're not dangerous. They can be really agitated though, and they'll come into contact with law enforcement very frequently. So that's probably a lot more realistic. Let's see, the paranoid disorders, so like paranoid personality disorder, you see that every once in a while. That have delusional disorders, sometimes they have delusions of persecution, stuff like that. Sometimes they can get violent, and typically it's directed at the people that they have the delusions regarding. Sometimes erotomatic delusions result in stalking and stuff like that, so people will think that, some celebrity is my one true love, and they'll stalk them and stalk them. John Hinckley, who shot President Reagan, was like that. He was obsessed with Jodie Foster. And then in the category of schizophrenia, there's lots of different types of schizophrenia. If you're not familiar with that, go look that up. But there's undifferentiated. The undifferentiated type shows psychotic symptoms that can't be classified into the other categories. And then there's a residual category where they've had one episode of psychosis, and there's still evidence of the symptoms continuing, but no other current symptoms. Now, the other types, catatonic type is really, if you haven't seen it, people will sit like in a chair for extended periods of time and they won't move. Sometimes their bodies are contorted into like weird positions. Sometimes they'll repeat like a phrase over and over and over again, or stereotype movements. Sometimes their behavior, though, we like to think of them almost like frozen, but sometimes they get incredibly agitated. So I've seen guys that were catatonic. I'm thinking of one young man that was actually a college student that had his first episode of psychosis when he was a freshman. And he would be catatonic most of the time, but then all of a sudden he would have these extreme periods of agitation where he'd just flip out. And if you got in his way, you might get hurt. So once in a while, the catatonic type will have aggressive behavior, but it's usually in relationship to that agitation, and it won't be directed at any particular target. Then you have the disorganized type of schizophrenia. People with the disorganized type will show behaviors that are just kind of weird. They'll have inappropriate affect. They might cry or laugh at very inappropriate times. Their thought patterns are all screwed up. So their language will come out kind of bizarre. They might have weird or odd clothing that they wear. They might wear too much clothing, inappropriate clothing. They might have strange mannerisms. They might withdraw. The disorganized type, although they're often bizarre, I haven't really, in my experiences, seen them to exhibit much violent behavior. They just kind of go off on their own. Now, the last type is paranoid type. And the schizophrenia paranoid type is really characterized by severe delusions and hallucinations. Typically, they're auditory. Usually, the auditory hallucinations are like, they're just, to be frank, they're kind of mean. So, like, the person will say, oh, yeah, I hear this voice, and it tells me how terrible of a person I am, that I should die, that I'm rotten, that I'm no good. It's like this voice that they hear over and over and over in their head that's really persecutory almost. But then sometimes the paranoid type will become convinced that other stuff is going on, that there's a conspiracy against them, that the IRS is following them or the Secret Service is following them, and they get these really bizarre delusions. So again, a delusion is a rigidly held belief that no matter what you present them to the contrary, they still hold on to the belief. And when the hallucinations turn to command hallucinations that tells the individual to hurt or murder or do something like that, that's when I kind of worry about violence in that schizophrenia, paranoid type population. And it's really fascinating to sit with somebody and say, oh, do you hear voices? And they say, yes. Well, what do the voices say? And they say, well, right now. And you say, yes. And they're like, well, the voices right now are telling me that I need to kill somebody. And you're sitting right across the table from them. It's kind of a bizarre scenario. So when you see a schizophrenia, paranoid type, and then if you combine it with other things like substance abuse, like you have somebody like that that's smoking crack cocaine or doing methamphetamines or something, that's like a recipe for disaster. And then they can have an access to disorder, a personality disorder like antisocial personality disorder, and things can go bad pretty quickly. So in that state mental hospital, you see a lot of people with a lot of different diagnoses. A lot of people that would just have access to diagnosis like antisocial personality disorder. They're not on any medication at all. Other guys that are diagnosed with just antisocial personality disorder are on all sorts of antipsychotic drugs. It's really a mess, but it is fascinating that you can see somebody come in that is like blatantly psychotic and delusional, or in the midst of a manic episode, and within a couple of weeks with the right medication, if they're compliant with their medication, they don't typically comply with their medication because those drugs aren't very fun to take. They make you feel terrible, and you can't force people to take their medication unless you get a court order to do so. But if they do take their medication, you can see somebody really change pretty drastically in a relatively short period of time. But the hospital that I worked at, they measured the stay and, I like months and months and months and months and months, not days. So it's not a short-term psychiatric facility, definitely long-term. So a couple other things that I want to address really quickly are competency to stand trial and not guilty by reason of insanity. We don't talk about the insanity defense too much here. I just want you to know that the insanity defense is not frequently used. It is not a get-out-of-jail-free card. I've worked with individuals that use the insanity defense for like shoplifting, and they've been in a state hospital for 25 years. If they would have not used the insanity defense, they probably would have been on like probation or something like that. So if you plead the insanity defense, they don't tell juries what happens to you, but you get sent to a state psychiatric facility. And there, once you're no longer mentally ill or no longer dangerous to yourself or others, then you can be released. But that does not frequently happen. So the insanity defense really has to do with your state of mind at the time of the offense. Now, different states have different rules. Some states don't even have the insanity defense. Like out west in Wyoming here, we're surrounded by states that don't have the insanity defense, like Montana, Idaho, Utah. But what you really want to know, and again, some states are more complex than others, but did the individual know the difference between right and wrong at the time of the offense? And sometimes we're concerned about if they had the ability to control their behavior. So, insanity defense at the time of the crime. Like this is Andrea Yates right here. her offenses, we were worried about her state of mind at the time of the crime. Now, you have tons of info on Andrea Yates in your book and a video on her. It's very interesting. In contrast, this is Jared Lee Lochner, who shot all those people in Tucson, Arizona, including U.S. Representative Gabriella Giffords. So what was his state of mind at the time of the crime? Did he know the difference between right and wrong? And that's what forensic psychologists or forensic psychiatrists are, that's what they do in criminal cases like that. They'll evaluate the individual, and inevitably, like the defense expert witnesses will say he did not know the difference between right and wrong, and the prosecution expert witnesses will say, well, he did. It's kind of ridiculous how this field works, but with Lochner's case, something else is very important. In order to go to trial, you have to have an understanding of the nature of the proceedings going on around you, and you have to have the ability to assist in your defense. Unfortunately, Lochner is so out of his mind that he has no clue what's going on, and so he can't assist in his defense, and he can't appreciate the nature of the trial. He doesn't know. A joke that I've heard before is that competency can be defined as knowing the difference between a grapefruit and a judge. Now, that's kind of ridiculous. But if you look at Lochner's behavior after the arrest, he's clearly mentally ill. Whether he will be found not guilty by reason of insanity, frankly, I have no idea. But he needs to be restored to competency before continuing with this trial. So an individual like that, if they're found incompetent to stand trial, will go to a state hospital like Florida State Hospital or Wyoming State Hospital, and will get the appropriate medication and treatment in order to get him ready to stand trial. So, competency deals with your state of mind now, right now, like at the trial. And competency is a requirement at all stages of your process through the criminal justice system, from arrest to, let's say, execution. You have to be competent to be executed. So that deals with your state of mind now. Insanity defense at the time of the crime. So here's a quick little map just so you can see this. It'd be interesting to just quickly review the McNaughton standard and the ALI standard. Your book goes over that. Not every state even has the insanity defense. Even though we talk about this and talk about it and talk about it, it's not used very frequently. So don't think that people just use the insanity defense. They have a mental disease or disorder or mental illness, and they just say, oh, I'm not guilty. That's not true. And there's other things like guilty but mentally ill, an extreme emotional disturbance, just to show diminished capacity so the individual doesn't have the full responsibility for the crime that they committed. So that's it. Go over the material. If you have any questions, let me know.